How we define it's actually a syndrome, that is constellations of certain signs and symptoms. Mostly it is caused by bacterial infection, but any infection, whether viral, parasites, right, can cause pneumonia. Characteristically, it is associated with the evidence of consolidation on a chest X-ray. But remember that consolidation in the chest X-ray can be non-infectious too. So there are a lot of other causes of consolidation, but when we talk about classical pneumonia, it should have a radiological evidence of consolidation. Long ago, this great physician, Sir William Osler, used to call pneumonia as a captain of men death. Even though it's no longer a captain of men death, but it is at least a lieutenant of men death. Because if you see that, it is the 5th leading cause of death in USA. And in developing country, it is considered to be one of the most common cause of hospitalization and death, both in children and in adults. Each year, about 5 million people die due to pneumonia worldwide. But the worst thing is that 96% of them are in the developing countries. So this is the worst thing, that majority of these patients die in the third world countries. Pneumonia used to kill 200 people per 100,000 per year in USA. But in 1940, there was a sudden reduction in the mortality from 200 per 100,000 to 70 per 100,000. And you know that this was because the first antibiotic was launched in 1940, and that was by the Alexander Fleming, penicillin. So this dramatically reduced the mortality from pneumonia. As the incidence of community-acquired pneumonia is concerned, you can see that from this graph that it usually affects in the extreme of age. Either you are very young, or whether you are old, then it usually in the young age, adolescence. I mean, the incidence of pneumonia is less. Then, as far as the mortality is concerned, again, mortality is maximum in patients who are above 65 years of age. This is what we are seeing with COVID-19 infection also, that people who are older than 60, 65, they tend to be dying more with that pneumonia. Now, other factors which are responsible beside age, which increases the mortality, the other is bacteremia. Bacteremia means that if you have a positive blood culture, if you isolate an organism in your blood, this means that your immunity is low and the infection has spread into the blood. So you are more likely to die from pneumonia. Again, there are certain pathogens like Staph aureus, methicillin-resistant Staph aureus, Pseudomonas, and Klebsiella. They are considered to be responsible for, they are considered to be more lethal organism, and they can cause more deaths. Similarly, extent of radiological involvement. Certain patients may have a small patch of consolidation, and certain other have extensive consolidation, and sometimes even both lungs. So if there is an extensive consolidation, if both lungs are involved, you are more likely to die. Degree of immunosuppression. People who are immunosuppressed, like diabetes, particularly if it has been poorly controlled, if they have chronic liver disease, if they have cardiac disease, malignancies, if they are on chemotherapy, they are the ones who are likely to die. Or HIV, for instance, that is also immunosuppression condition. And again, excessive consumption of alcohol can contribute towards that. As I mentioned to you, that the mortality also depends upon the etiological agent. For instance, Pseudomonas is shown here, highest, Klebsiella pneumonia second, and Staph aureus. I mean, these are the three main organisms responsible for causing high mortality. Now, how a person develops a pneumonia, I think these are the three mechanisms. One is the inhalation. This is the most common route for any organism to enter into your lungs. So if you breathe in an air which is filled with organism, you are going to take them inside. And if your defense are low, you are going to develop chest infections. I mean, this is what we are seeing again these days, the COVID-19 infections, that this main source is droplet infection. So same is majority of the cases. That's why it's always advisable that you are visiting the ward, you should be wearing a mask, because hospital surroundings are highly polluted with organisms. The second is the aspiration. Aspiration is commonly seen in patients who are bedridden, having dementia, right? They can tend to aspirate whatever food is being given to these people who are being fed while in a lying position. They are likely to aspirate. Secondly, people who have got postnasal drip, they are also responsible that a lot of secretions you extreme of ages, obesity, exercise, is a protective mechanism. If you are active or if you have a sedentary life, you are more likely to develop. Similarly, smoking, peripheral vascular disease, asthma, COPD, immunosuppression, HIV. People who are living in old people home or in the institution, they are likely to, because if one person gets an infection, then he spread it to the across. Similarly, hospitals are also a source of infection. So be careful when you're visiting hospital. It's better to wear a mask. Dementia, again, as I mentioned to you, these are the patients who are bedridden and they are likely to develop infection because of that. Now, how do we classify pneumonia? Pneumonia has been classified on the basis of X-ray finding, on the basis of organism responsible for causing pneumonia, or on the basis of clinical classification. So we will discuss each one by one. First is the radiological classification. On the radiological basis, depending upon the extent of involvement, we can call as a lobar pneumonia, segmental pneumonia, or subsegmental pneumonia. Not only that, X-ray is the mainstay in the treatment of pneumonia. It not only makes you or helps you in making a diagnosis, but it can also detect associated lung diseases like lung cancer, COPD, or bronchiectasis, which are there in addition to pneumonia. Sometimes it can give you a clue depending upon how the X-ray look like as the possible causative agent. We will talk about that later. It can also assess on the severity of the disease. As I mentioned to you, if you have a multilobar pneumonia, you are more likely to die from this. And also your response to the therapy. If the X-ray is getting better, that means the person is responding to your treatment. Now, this is an X-ray of lobar consolidation. This is right upper lobe, and you can see that the whole area is appearing white. But if you carefully look at these are the these are the black lines which are visible in this white area. This is called, this is a hallmark of consolidation, not pneumonia consolidation. Any consolidation will cause this, and this is called air bronchogram. Usually air, like there, the bronchi are not visible, but here the bronchi are visible because they have air inside and the surrounding alveoli have become white due to the fluid in there. So this is a classical sign of consolidation, air bronchogram. And here you can see the upper lobe consolidation and at the same time bowing of the fissure, horizontal fissure upward. So there is some element of collapse in the upper lobe. So this is classical upper lobe pneumonia, lobar pneumonia. And this is left lower lobe pneumonia. Again, you can see that bronchi are visible. These are air bronchogram. So this is the classical sign of. So this is the X-ray of right middle lobe consolidation. You can see that the shadow is adjacent to the heart. Heart border is not clearly visible. This is the right middle lobe consolidation. On a lateral view, it will appear on the heart. So there will be a triangular area over the heart, which is more dense, and this is indicate the right middle lobe pneumonia. This is the right lower lobe pneumonia. You can see that the diaphragm is not visible because the right lower lobe lies over the lower lobe lies over the diaphragm. So this, when two densities are the same, two objects are of the same density, then you will not see the clear line between them. So that's why here the diaphragm is visible, because here there is an air on the top of that. This is called Sullet sign. That is, if the two densities are of same density, so they will not clearly marked out. So this is the lower lobe pneumonia, and if you see on the lateral view, you can see that this is appearing as a lateral posteriorly located pneumonia. How do we say that? Because when you trace these bodies of the vertebrae, as you go down, they become more and more black. But here again, you can see the white because there is a fluid which has come into the lungs or into the alveoli, therefore it is appearing white. So right lower lobe pneumonia, bilateral pneumonia. Again, as I mentioned to you, bilateral pneumonia is a serious thing. So there is bilateral pneumonia. left upper lobe pneumonia. Here you can see the left upper lobe pneumonia. Now, these are all the example of these lobar pneumonia. Here you can also see the lobar pneumonia with some air bronchogram there. But here you can see a small portion of the lobe. Lobe is made of different segments. For instance, middle lobe is made of two segments, medial and lateral. So here it is a segmental pneumonia, less than a lobe which has been involved. It's called segmental pneumonia. And then when there is even less than a segmental pneumonia, it is called subsegmental pneumonia or bronchopneumonia, where you will see cotton wool patches scattered all over the lung. So this is subsegmental pneumonia. Now, the second classification is etiological classification depending upon the organism. Remember that the most common organism in community-acquired pneumonia is Streptococcus pneumoniae. So this is considered to be majority of the cases, 60% are because of Streptococcus pneumonia. Then there can be other like Mycoplasma, H. influenza viruses, Haemophilus influenzae, chlamydia, and you can name any organism that will be responsible for causing. So there are certain less likely causes, which is pneumocystic carinae, actinomycosis, nocardia, usually seen in immunocompromised patients. And remember that in around here it is written 20%, 50% of the cases we are not being able to find any cause or any pathogen in all the tests which we do. So we have to treat the pneumonia blindly. Now, this is the most important classification which we call as clinical, depending upon where a person has developed pneumonia. Either it is in the community, if he's coming from the community, this is called community acquired. If he has developed pneumonia after admission in the hospital, after 48 hours of admission in the hospital, or within 48 hours of discharge from the hospital, this is called nosocomial pneumonia. Then, as I said to you, old people, aspiration is again another common type of pneumonia, and pneumonia in immunocompromised ventilator-associated pneumonias. So, depending upon where you have got the pneumonia, it helps you in knowing what would be the possible pathogen which is responsible for causing pneumonia. Now, once how to go about in managing pneumonia. First is the recognition of the condition, that you have to have a high index of suspicion to recognize pneumonia. Because if you don't recognize, you are going to treat poorly, and poorly treated pneumonia can be associated with a lot of complications. So first thing is that you recognize the condition, then identify the severity of the pneumonia, because you have to decide whether this patient is going to be treated at home or in the hospital or in the ICU. So severity assessment is important in pneumonia. And then you do some investigation, which are microbial and non-microbial investigation, and then you start the treatment. There is two possibilities: either the person is going to deteriorate or patient is going to show the recovery. So this is the algorithm which we tend to follow in the management. So we will take one by one recognition of the condition. Remember that there is no distinguished clinical or radiological feature which can tell you which is the organism. They can suggest, but they cannot confirm that this is the pathogen and that's the antibiotic you have to use. So this is one of the problems when you're dealing with pneumonia. Now, recognition of pneumonia, I mean, typically the pneumonia will present with fever and rigors, sudden onset of high-grade fever with rigors. Patient may be dyspneic, patient may be having pain in the chest because of the involvement of pleura, which is a pleuritic type of pain that is increases of deep inspiration. Then you can have cough. Sometimes patient may produce rusty, little reddish tinge sputum, and there are physical signs of consolidation. Physical signs of consolidation, we all know that there will be dullness to percussion, there will be bronchial breathing, and possibly agophony. These three signs are the characteristic signs of consolidation clinically. But remember that these typical features are only present in 25 to 33% of the patients. Atypical presentation may be also there, particularly in very young and old or immunocompromised patients. Non-respiratory symptoms like nausea, vomiting, diarrhea, and abdominal pain may be responsible in 20% of the patient. They may not have a respiratory problem, but they are complaining of nausea and vomiting. And Sometimes lower lobe pneumonia can present as an acute abdomen because of the tenderness. There will be so much tenderness and guarding in the upper right quadrant or the left quadrant, um, uh, in the upper or left hypochondric region. So patient will have a very acute pain and there will be guarding, so looking like an acute abdomen. And it is said that if you do not find any cause for acute abdomen, always include a chest x-ray in your investigation for acute abdomen, because you may find lower lobe pneumonia, which can explain the cause of this tenderness and guarding. So once we have identified the pneumonia, we have to see the severity of the pneumonia. There are different ways of assessing the severity of pneumonia, like there may be clinical signs like confusion, systolic, diastolic blood pressure less than 60, respiratory rate greater than 30, laboratory findings like lymphocytosis less than 1,000, or very high lymphocyte count, blood urea if it is increased, if patient is hypoxic in the room air. These are all indicative of severe pneumonia. Again, on the X-ray, when there are multilobular involvement, or you have a bacteremia that you isolate blood from the culture. This is the simplest way of assessing the severity and deciding how we are going to treat or where are we going to treat this patient. This is called rule of curve 69. This is the British rule which Britishers like to follow. And this is basically very easy in your clinical practice. You can assess. First is that whether person is mentally clear, oriented in time and space, or is he confused and there is some clouding of consciousness. So first thing you have to look at. Similarly, the second is blood urea nitrogen if it is greater than 30. If the patient respiratory rate is greater than 30, and blood pressure, systolic blood pressure less than 90. Age above 65. That's why it's called curve 65. C stands for confusion, U for raised urea, R for raised respiratory rate, B for low blood pressure. So these 5 points, and 65 is the age. So if you have got any one of this feature, this will be called as curve 1. So you can treat curve 0 or curve 1 can be easily treated at home. Curve 2, you can keep them for 24 hours in the hospital. If they are improving, you can send them home. Curve 3, definitely, that is 3 of these 5 features are there, then you have to admit in the medical ward. If 4 or 5 of the feature, almost all the features are present, then I am afraid that you have to keep this patient in ICU. The management should be in ICU. There is another scoring system which Americans like to follow, which is a bit more detailed. I would not like to go into that detail, but remember that this is called port index. Port index is taking into consideration the age, the comorbidities, the clinical finding, and investigation. So it is difficult to remember all this. Curve 65 is very easy to remember, but it is little considered to be more reliable in assessing where to patient is going to be treated and what is the mortality associated. So if you are in the class 1, there is no mortality. But in class 2, I mean, there are more than 70% chances of dying. So as the class increases, the chances of dying also increases. This is how it should be. That mortality in class 1, less than 1% of the patient, 0.1 to 0.4% will die. Therefore, they can be treated as an outpatient. If it is class 3 and PSI score is less than 70, then it is again less than 1%, you can treat them. But if it is class 5 and PSI score, every point has got, let me show you again, that every point, for instance, if the man is age greater than 50, then you will give 50 points to this. If it is a healthcare resident and in an old people home, 10 points. If he has got a neoplasm, 30 points. So it depends upon how many points you add up all these points, which you can't remember that, and then you divide, depending upon what is the score. This is called port severity index. So depending upon how many points you have scored, you can be put into different classes, class 1, class 2, class 3. In class 5, where the score is greater than 130, then definitely the mortality is very high, about 30 to 35% will die, and these patients should be kept in the hospital. Now, once we have decided where are we going to treat, in the community, in the hospital, in the ward, or in the ICU, we have to do certain non-microbial investigation and microbial investigation. Non-microbial investigation is the complete blood picture, which will show you whether the white cell count is raised or lower than normal. That is, both are having a prognostic influence. Similarly, urea and creatinine, as I said to you, that urea also denotes the significance of the disease and mortality. ABGs, whether patient is hypoxic or not, and X-ray, as I already have been showing, been shown to you, that if there is an extensive radiological involvement, it's a bad prognostic sign. So all these tests not only help in the management, but also assessing the severity. Now, microbial, this is to find out what would be the possible pathogen. Sputum, the moment the patient comes in, it is much better that you do collect the sputum, do a gram staining, and send it for culture sensitivity. A gram staining can give you a very good idea of what would be the possible pathogen. In Pakistan, where TB is very common and can present like typical pneumonia, so every patient should have a sputum acid-fast bacilli examination also. If a patient is unable to produce sputum, then you can nebulize them with a concentrator, hypertonic saline, steam inhalation, so that they can expectorate and you can send the sputum for culture. The other test, is the biomarkers which are now being used. One is called ProBNP. ProBNP is basically a beta natriuretic peptide, and it shows the severity of pneumonia also. It helps in assessing the severity. That is, if increased level are there, it denotes that the patient may need mechanical ventilation with a high mortality. Up to 90 to 98% patients will die from this if it is low. If it is high, so pro-BNP, and similarly procalcitonin. Procalcitonin increased in severe infections and sepsis. Level higher in the bacteria compared to viral infection. The level, if it is less than, it also helps in deciding whether it is a bacterial pneumonia or a non-bacterial, whether we should start the antibiotic or not. If it is less than 0.5 milligram per liter, then the chances are the negative predicted value is and negative and positive predicted values are very high. So you don't need, if the procalcitonin is very low, you don't need to treat them with antibiotic. It also sometimes helps in assessing when we should stop the antibiotic. Now, as I mentioned to you, sputum examination is very important. So a good quality sputum should be seen. And it is also, remember that quite often when you will see the sputum report, you will see that there is a large number of polymorph. Polymorph only tells you that this is a good quality sputum coming from the alveoli, because always polymorph will be shed into the sputum. But if you see a large number of squamous cells, normally in a sputum sample, they should be tested less than 10 per high power field. But if it is greater than 10, that means it is not a suitable sputum sample, because it is mostly saliva, which has got more squamous epithelial cells. It should be transported as early as possible, and semi-quantitative, that is the number of organisms which have been detected or the number of colonies which have been detected, should be mentioned in the sputum culture sensitivity report. But remember that sputum culture is only sensitive, only give you an idea in 50% of the cases. But in pneumococcal pneumonia, it may be in 80% of the cases. If the person has not taken a prior antibiotic, then 80% of the chances that you can detect this antibiotic. This is how streptococcal pneumonia look like, as a pair clump gram-positive organism. Sometimes the tracheal secretion or the sputum cannot be, patient is not producing a sputum despite giving them concentrator, saline nebulization, steam inhalation, then we have got an option that we can do a transtracheal aspiration directly by putting a needle here into the trachea and getting the sputum out. Or sometimes you can do a bronchoscopy to get the sputum, or sometimes you go right from the skin, chest, and aspirate directly from there, percutaneous aspiration. But nobody tends to do that. If we don't aspirate, we usually go for a bronchoscopy. Blood cultures are very important and certain serological tests. If a person has got pleural fluid, pleural effusion, which again a common problem, then pleural fluid should be aspirated and sent for culture, ideally in a blood culture bottle, and pneumococcal antigens should be detected in the pleural fluid. It can also be detected in the urine, pneumococcal antigen, and positive in 70% of the cases. And an important thing is that even if the person has taken antibiotic, the blood culture, the sputum culture may not become reliable, but presence of pneumococcal antigen can show you which organism is there. Blood cultures is very important or mandatory in cases of pneumonia, provided the person has not taken antibiotic. But the problem with blood culture is that it is only positive in 10% of the cases. So sensitivity is very low, but if it is positive, then you have hit the bullseye. You know what is the organism and you can directly direct your therapy towards that. Treatment wise, oxygen should be given, particularly if the patient is hypoxic. IV fluids, if because the patient can very easily dehydrated because of the sweating, increased respiratory rate. If there is a pleuritic chest pain because of the involvement of pleura, analgesic should be given. If there is bronchoconstriction, bronchodilator and physiotherapy, which helps in the expectorating. Now, the real question comes in, what antibiotic do we have to use in this patient? Because by the time you have to start the antibiotic, you don't know what is the possible pathogen. So there has to be a guess, a sensible guess, and guess depends upon a lot of these factors, like origin of the infection, whether it's a community acquired or hospital acquired infection, seasonal changes, age of the patient, chronic liver disease, chronic lung disease, clinical and radiological features, travel history of travel abroad, contact with the birds. So all these history, there should be history included in the history. Now the first thing is, where has the patient got the infection? For instance, if it is a community acquired, as I mentioned to you, Streptococcus pneumoniae will be the most common organism. The natural influenza, chlamydia. So whatever antibiotic you are going to choose, they should be covering these pathogens. These are classical pathogens, and there are certain atypical pathogens like Mycoplasma, Legionella. These are atypical organisms. Gram-negative organisms are very less likely that they will be acquired from the community. The real issue is that in 40 to 60% of the cases, we cannot find any cause when we have to start the treatment. And sometimes there can be more than one organism involved. Now, the main difference is that if it is a hospital-acquired infection, then gram-negative organism like Klebsiella, E. coli, Pseudomonas becomes the most important pathogen in there. So antibiotic has to be directed towards that. Similarly, in aspiration pneumonia, the pathogen might be different. Similarly, in immunocompromised, the pathogens will be different. So different antibiotic has to be used in these conditions. Seasonal changes. For instance, influenza epidemic is common in winter, January to April, and the pneumonia which occurs after getting a flu is usually a staphylococcal pneumonia, so it has to be covered. Age, for instance, infants, viruses, H influenza, Staph aureus is common, and for school-going, Mycoplasma is more important organism. Chronic liver, if chronic lung disease, those who have got a COPD or bronchitis, H influenza and Moraxilla catarrhalis becomes more important. Clinical and laboratory findings, prodromal symptoms. If you have got a history of headache, muscle ache, pain in the body before you typically develop pneumonia for a few days, that is a prolonged prodromal symptoms, then it is more likely to be viral or atypical. When it is very sudden onset of high-grade fever, streptococcal pneumonia or staphylococcal pneumonia should be considered. Another thing is herpes labialis. Some patient with pneumonia can develop cold sores over the lips. These are basically herpes simplex. If you find in a pneumonia patient herpes simplex, then you can be sure that this is basically a pneumococcal pneumonia. So it is almost a sort of pathognomonic sign. Laboratory hyponatremia, commonly seen in Legionella, cold agglutinin in mycoplasma. X-ray also sometimes give you a clue in the diagnosis. For instance, if it is a lobar consolidation, mycoplasma, or staphylococcal pneumonia. If it is upper lobe lobar consolidation, Klebsiella is more likely to be an organism. Chlamydia history, if you have got a contact with the bird and the bird is ill, then it is very likely. If you have stayed in the hospital, in the hotel, if you have traveled abroad, Legionella should be considered. The other important thing which you have to see is the delay in starting the antibiotic. I mean, each hour lost in starting once you have made a diagnosis, you increases the mortality in these patients by 7 to 8%. So you can see that if you have diagnosed it on the first hour and if you delay it, you can see that the mortality will be delay in treatment per hour increases the mortality by um, by 7 to 8%. So the chances of survival will go down as the time passes between the diagnosis and starting. So from this, I mean, it was concluded that the antibiotic should be started in cases of pneumonia as soon as possible. The other important thing is that you have not only you have to start the antibiotic quickly, but you have to start the antibiotic correctly, because this has been shown that if your first choice of antibiotic is correct, then the mortality is going to be low. But after getting a culture sensitive blood or sputum, and you decide that the patient is not responding and your choice was wrong, then if you have to switch on the antibiotic, then the chances is that your patient is going to die from that. So two things important in managing or starting the antibiotic: correct antibiotic and as early as possible. How these two things can be possible? The best thing is that you take the help from the local guidelines, because they are evidence-based and they give you an idea which are the organism and in which condition you have to start which antibiotic. So the guidelines give you a rationale to use the proper antibiotic. And this is, I'm going to be the last slide, which basically is taken from the guidelines. And this is showing that if the person is previously healthy, there is no comorbidities, he has not received the antibiotic in the last 3 months, no matter for any reason, even for a UTI or anything else, if he has not received the antibiotic, then simple macrolide like erythromycin or doxycycline like vibramycin can be given. But if he has received antibiotic, and in our setup, most of the time they have already received, then either respiratory quinolone or advanced macrolide plus beta-lactam. So two antibiotic or a single antibiotic has to be used if they have received. If there is a comorbidity, again the same, beta-lactam with macrolide or a respiratory quinolone. And similarly, if they have received recent antibiotic with comorbidities, then you have to give them a combination of antibiotic. In places like if you have got a high resistance to strep pneumoniae, then the best thing is that you can go on the respiratory quinolone. That is moxifloxacin, levofloxacin, and gatifloxacin. The only issue I would like to point out is that in Pakistan, there can be a confusion with TB, because sometimes the TB can present in the similar way. So if you are suspecting that there is a possibility of TB, then don't give them quinolone. Then it will be better that you stick on to the macrolides as well as beta-lactam antibiotic. So that will be the choice. Macrolide is given, beta-lactam is given to treat the most common pathogen, that is the strep pneumoniae, and macrolide is given to cover the atypical organism like mycoplasma, Legionella, chlamydia. These organisms are not covered with majority of the antibiotic. But if we have to give them respiratory quinolone, the advantage of giving respiratory quinolone is that the disadvantage is that it can treat TB also. So that causes a confusion. The advantage is that it covers both the streptococcal pneumonia as well as atypical mycoplasma Legionella. So both organisms which are common in the community acquired pneumonia, they can be treated with single antibiotic. So, and as I said to you, respiratory fluoroquinolones are moxifloxacin, levofloxacin, and Gemifloxacin